Hi. How are you, Chris?
Good. I missed you.
I know I missed you too. It's so good to see you. And sorry I was out last week. Thank you for covering as always. I know we have a million questions that I just keep seeing, and I'm like, oh my gosh, we have so much to catch up on. But as always, I love to just connect and see you. And I hope that today we can do that for other folks. So just a reminder, I'll kind of hop in. If you guys can please let us know in your right-hand pane who you are, where you're joining from, and any questions that you have for today. Today is one of our Ask the Experts. I'm going to let Chris talk a little bit about our live stream next week and our special guest, and talk a little bit about what we're excited about, what we're hoping we're going to get to cover, and then we will hop into today like we always do. Good to see you, Chris.
Good to see you as well. So as Liz said, this is all about you. So we need to hear where you're from, maybe what you're struggling with right now, a question that you have from us, anything that you'd like to present to us. We are here to support. Like Liz said, this is an Ask the Experts, so we're really here as a town hall, basically to kind of like answer your calls, have the public come to us, and we're here to answer your questions. Next week is one of our lunch and learns. Obviously, Liz and Peace of Mind coined that. Very honored to be a part of it. And so what we like to do is bring a topic that either comes from the community, which I believe this one was, either through going to iocdf.org/peace of mind and putting in there in our Peace of Mind community what you are interested in hearing about, or from the questions we get. And so a lot of people had questions about relationship OCD. So we are fortunate enough to have Shiva. She's a therapist out here, right? Like, I think her office is like 10 or 15 minutes from here, but she just wrote a new book on relationship OCD. I should have had that queued, but I will get that queued and announce it in a second. But she is going to come talk about just relationship OCD. She and I have talked personally. I know that she's going to open up about her own experience. I dealt with relationship OCD. It's a very common subtype, but also kind of just clinical insights and stuff from her book. So Liz and I will be moderating that. So if you are interested in relationship OCD, know somebody who is, or someone struggling through it, please direct them to that live stream next Wednesday, 9 a.m. Pacific, 12 Eastern. And lastly, what I'll say about it is, if you don't deal with relationship OCD and you find yourself wanting to kind of maybe skip that week, what I always remind people is, unfortunately, OCD loves to switch subtypes. And one thing I see for a lot of people is they didn't deal with relationship OCD because their OCD was so bad they weren't able to be in a relationship. Then they get in a relationship and relationship OCD presents itself. So definitely be there next week. But we are excited to be here today.
And the one thing I want to add in, Chris, I don't know if you see this, is I do see relationship OCD sometimes like other subtypes, but this one in particular, where sometimes it's not always used correctly. And what I mean by that is that I want to make sure next week we also talk a little bit about what relationship OCD is and what it is not. Because I do think that sometimes, in general, we find that it's like, oh, if I'm obsessing about my ex, or I'm obsessing about, somebody I'm interested in, that must be relationship OCD. But can we really talk about what defines it as being OCD versus what doesn't? And the reason why this is really important, I want you guys to hear me saying this, I'd love for us to talk a little bit about this, Chris, is that sometimes I think when we live with OCD, we start to like all of the things that we might struggle with. It's not easy, but it makes sense for us to categorize all of them as OCD. And I actually think that's really destructive. And I think it's something we need to be really careful about. And it's not because there's anything negative about it being OCD or not. It's actually because the treatment, right? Treatment should be specialized treatment. And so when something is OCD, we want to treat it as OCD, which is specialized OCD treatment. But if it isn't OCD, we want to be able to treat it for that, right? And be able to make sure we're engaging in the right treatment. And relationship OCD is one of the subtypes I've seen where it is often misunderstood. And sometimes it's often missed when it is relationship OCD, but also sometimes I see people labeling something as relationship OCD when it isn't. So things like, just obsessing about our ex or stalking our ex, or certain things that that actually might be categorized as something else and would be better treated if we understood what it really is versus identifying it as OCD. Does that make sense, Chris? And do you agree?
100,000%. I've had people refer to our treatment center who have borderline personality disorder and are displaying much different behaviors because of the fear of abandonment. And therefore, it's not an intrusive thought. It's not ego dystonic. Like it's this fear of being abandoned and they have other traits of BPD and they got misdiagnosed to this. Or like you said, sometimes people will hear relationship OCD and think, oh, I have it because I missed my ex. And so I'm really excited for us to just kind of go in there and clinically define like what our OCD is, so that people who are watching either are going to discover, hey, wait a second, I do have that, or vice versa. Maybe I don't have that. And there's a better way to go about some of the struggles that I'm having around a relationship in my life.
And I think, this is something that I just want us to kind of, maybe we should do an entire talk on comorbidities one day, because I think it would be important, is that most people, a lot of people living with OCD also live with comorbid conditions. And I think sometimes it's like, but wait, you're saying I don't have OCD. That's not necessarily what we're saying. It's important for us to say, okay, this is what's my OCD, and this is actually what may not be my OCD. So for example, I definitely have some OCPD tendencies, right? Like if you go to my house, my fridge is organized a certain way, like my closet is organized a certain way. That's more my OCPD in the sense that I enjoy it. My husband might not really enjoy it, but like it brings me some pleasure, right? And it's how I function, but it's not my OCD. And it's important because I don't want to label that as my OCD when it isn't, because that perpetuates the stigma, but it also makes treatment and things be confusing because it is a little bit different, right? The organization that I engage in is actually something I enjoy, where one of the main parts of OCD is that it isn't enjoyable, right? It's ego dystonic. We don't enjoy it. It brings us distress. It doesn't bring us pleasure. And so it's just really important for us to say, okay, not to just say, oh, this is OCD, this is OCD, this is OCD. It's like, well, wait, like, what is OCD so we can treat it as OCD, and what could the other things be so we can treat them the way they need to be treated? Evidence-based interventions don't exist just for OCD. They exist for almost every single mental health diagnosis. And we don't want to use, yes, ERP is evidence-based for OCD, but it's not evidence-based for other things. And so if you're using ERP for something that isn't OCD, it would make sense if it's not getting better or easier or continues to be just as challenging. So important to just keep in mind. I wanted to throw that out there. And next week, I will be sure that we ask a lot of questions around, okay, so what is our OCD and when is it not our OCD and how do you differentiate?
Yes. I'm excited. So everybody please be there, because like I said, even if you don't think you're going through it, you may be, or it may be a future subtype. And I think that's why it's so important to learn all about the disorder that you are trying to defeat. So I think
100%. So let's hop into questions. We have so many pre-submitted questions that I want us to get to. And of course, we will do our best to get to any questions you submit live as well. Hi to everyone. I love seeing people from across the country, but from someone Kostas from Greece and all across the world. It's so fun. Of course, Chris and I are both jealous that we're sitting in our office instead of sitting in Greece. But
I know, and I'm half Greek, and I was supposed to go there in 2020. So I'm planning on going either this year or next. So then I can see my people. I can reconnect with my heritage. So I'm excited.
Yes. All right. So the last question that was from, or the first question from the last live, Chris, that I want to hop right into is, how do you deal with the situation where you have thoughts of liking your own brother and you want to change it, but you can't?
Yeah. So when we talk about intrusive thoughts around, obviously in this topic, it would be incest. We obviously have a visceral, very negative, very kind of revolting reaction to that. And that's OCD's trick to get in. So naturally, what you would think the best thing to do would be to deny it, to argue why you don't like your brother, to ask for reassurance, to look things up, etc. The problem is the more of your energy that you give, aka a compulsion, the more it starts to feel real. And what I always tell people is compulsions equal confusion. The more compulsions you do, the more you're confused, the more you don't understand, and the more that you're struggling. And so in this, we have to kind of take it as, hey, this is OCD again, trying to get me to locate certainty so I can walk away from this conversation in my brain and be 100% certain I'm not in love with my brother. That will never happen. OCD will always move those goalposts, and the more compulsions you do, the more you're lost, the more you're confused, and the more that you're struggling. And so what we want to do is break that OCD cycle and take our power away, which is giving into those compulsions. And so it's not fun. I always warn my clients, OCD treatment isn't fun, but it's effective. And so what we need to do here is we need to start to accept that the possibility is, I have intrusive thoughts about liking my brother. I'm going to take a passive approach on that, meaning I'm not going to do mental compulsions, figure out, and I'm going to walk away from this conversation. And what starts to happen when you take away your energy towards the conversation, there's less conflict, there's less back and forth. And then you start to identify a thought as a thought, and you don't treat it as if it's this statement that you have to spend your whole life trying to prove. I understand. I just want to throw a real quick little personal thing. One of the first things now I wish that I recognized was this subtype. My sister looks like Liz. She looks nothing like me. My sister and Liz look like twins. And when I was a kid, everybody thought we were boyfriend and girlfriend because we'd be waiting for the bus together. We'd be waiting to get picked up. And, you know, it was back at the age where it was like gross to have a girlfriend. And it wasn't that I thought I liked my sister, but because I have OCD, my brain was like paranoid that people thought that I liked my sister. And so I would avoid standing next to her. I'd be mean to her. And I did all these horrific things that I recognize as OCD now. And that is why that thought stuck around forever. So I promise you, the compulsions is actually what's keeping it around.
Yeah, so I love it. Compulsions equal confusion, and solving gets us stuck, right? So it's important to remember that anytime we try to go down this path to solve and to understand and to get more clarity, we will get more stuck, right? And so what we actually want to do is, as Chris mentioned, it's about not doing compulsions. It's about not trying to solve, and it's about allowing the thought and the uncertainty to be there. Right? What we don't want to do is say, okay, we're not going to do compulsions, but we're just going to suppress it and try to distract ourselves, because that thought will keep following us. The way that the thoughts no longer have power and no longer bother us is if we don't respond to them like we're afraid of them. If instead we kind of welcome them of like, okay, like, yeah, so like maybe I am interested in my sibling, and like, okay, like it is what it is. Thanks, brain. Like, thanks for that thought. Like, that's an interesting thought. I'm going to choose to still move on with my day despite the thought, right? We're not trying to solve it and go down to the path of rumination and understanding it. Uncertainty, I want to be clear, because I think sometimes when we say lean into uncertainty, people think we're saying like, you need to go down the worst path and spend 5 hours thinking about dating your sibling and being with them. Like, that isn't not only is it not really useful, but it's not feasible. We have a life to live. But what we're saying is that you just allow the uncertainty to be present. So you don't try to suppress it and get rid of it, because it will chase you. You allow it to be there. So you don't compulse, number one, and then you allow the fear, the anxiety, the thought to be present. You acknowledge it, right? You don't run from it, and you move on. And what happens is when we acknowledge it in a kind of more calm way of like, oh, like, thanks for that thought. That's interesting. Not going to figure that out. And instead, I'm going to still go to work and go on with my day today. The thought doesn't have power anymore, because we're not responding to it that we're afraid of it, right? But if automatically it's like it gives us this surge of anxiety and we're like, why am I having this? I need to figure it out. I need to solve it. And we start compulsing, we will always get more confused and stuck. Or if we're like, I can't think about this, I have to suppress it, and I just need to move on and distract, it will keep popping up, right? So we don't do compulsions. That's the response prevention. The exposure was the thought itself, right? This was an unplanned exposure. It just came up. But then again, it's, can we lean into the fear as well? And can we actually allow the fear to be there without trying to avoid it? Because if we try to avoid the fear, avoidance plays that same role as a compulsion.
Exactly. Well said. Well said.
Next question, Chris. ERP has helped me a lot. But whenever I see a person, I don't want to think of their toilet habits. Can I change my reaction?
Yeah, you know what? I'm glad this question came up right after, because it's very similar in the sense that when we have thoughts that give us a repulsing feeling, so obviously we know that we're going to have a negative feeling when we think about our sibling in a sexual manner, or when we think about toilet habits. I mean, it's not the first thing you want to think of when you think of someone. The problem is, just like Liz was saying, and just like we were discussing, is that resistance to that thought is what's going to bring it back. So I always tell clients, like, when you push against the thought push back harder. So the problem is, let's say I go out and I see a friend and we're about to eat, and the thoughts of their toilet habits come in. If I thought stop, if I'm like, nope, can't think of that, let me distract, let me divert, let me go, I can't stop, leave me alone, this is gross, we're about to eat. All that's going to happen is that thought is going to turn up the volume, and then it gets so loud to the point that you just feel like giving up and you want to go home early, you don't want to be there. It is not enjoyable. I always preface that, but you got to let the thought finish off on its own. And so I think of it as like you're in your house and there's a commercial or a TV show playing in the background, and you got to let it play out, because the more you try to stop that thought, the louder it's going to get. So is it going to be enjoyable to let the thought organically pass through of their toilet habits? No. But I promise you, your emotional response of letting it go through is a lot less than stopping it, because I'm telling you, I tried that for years before therapy. It does not work.
Yeah, it doesn't work at all. And the thing is like, what I would always push to is, when you have fully leaned into your fear, your triggers, your OCD, you should have no fear of that fear anymore, right? So I might still have sexual intrusive thoughts. Like I still have sexual intrusive thoughts. I'm not going to say I might. I definitely do. But I'm not afraid of sexual intrusive thoughts. And I actually can like even think about the most recent sexual intrusive thought that I had, and it might kind of gross me out because I'm like, oh, like that's a bad thought, but it doesn't trigger me. It doesn't bring me anxiety. And so if you still find that like you're ruminating about someone's bathroom habits, or you're still wanting to not have to think about those because thinking about them scares you, you might need to lean in a little bit more to that fear and to that anxiety, because it may mean that we didn't address the fear all the way at the core. Maybe we've addressed some of our symptoms and we're no longer super symptomatic around that trigger, but have we addressed some of the core fears, right? Chris, I don't know if you would agree, but I think the big indicator for me of like, okay, have I done my work in this OCD area for myself is, do I still have any anxiety around the fear? Or can I think about it freely and it doesn't really bother me at all?
Yeah, exactly. And when we talk about acceptance, I always like to preface this in session as like, acceptance doesn't mean agreement. Like acceptance
That's
isn't
right.
like, yay, I'm about to do taxes. Like I accept that taxes happen, but I don't agree with them. I hate them. Nobody likes taxes, right? The difference with this one too is like when you accept that thoughts are going to be there, you tolerate them, you acknowledge them, etc. What you're doing is you're allowing them to just be. And like anything, it's kind of like little spiders in your house. If you just leave them alone, they stay in the corner. It's the same kind of thing. So I think the thing that gets people tripped up is that backdoor anxiety of like, wait, now that I'm not fighting it anymore, I'm not as triggered anymore, does this now mean I like it? And that's one of OCD's like final tricks to get you to come back to the conversation. So once again, don't be fooled by anything that OCD does to keep you around.
Totally. Any thoughts, Chris, on when one is noticing that a barrier to having willingness to challenge or treat severe OCD is the feeling or thought of what was the point of committing to all this energy and time to OCD?
Yeah, I would say, we talk a lot about OCD and kind of identity sometimes in session. I think it's, I run a young adult support group, and I think this comment right here is almost super relevant for that age group, especially because you feel like this has been your focus. It would be just like somebody who spent 30 years in a field and gets laid off and then just feels can't find a job in the field and feels burnt out and angry that they spent so many years in a field and don't have the job. A lot of people will say that. They're like, but Chris, this is all I know. Like I have been spending so much time, so much energy into the OCD, and I feel like I'm just giving up. And one of the things that I like about ERP treatment now that maybe wasn't as discussed early on is this idea of values and goals and creating identity. So all of that energy that you're putting in, man, if we could bottle that up and sell it, we would be selling. Every Walmart, Target, and 7-Eleven would be having us front and center. And that energy, once you drop the OCD the best that you can, you will have that energy to put in other things. Look at Liz. She puts her energy in being a mom, being an amazing friend, being an incredible wife, like running one of the best like residential treatment centers in the world. I mean, all of that energy is way more better spent. Like Liz is going to remember those moments her whole life. She's not going to remember the hours in her head, the compulsions. I mean, all of that time that we spend on it, there's no return. So it can feel very scary, daunting, and almost like sad to like drop the OCD. And, I know Ethan's done a lot of talks on this, is that life after OCD kind of talk of where, you almost feel sadness once you drop the OCD, because it's like, oh my God, what do I have left? But that's why you've got to find out what makes you, why are you unique, and what do you care about? And that energy is better spent. And I promise you, and Liz and I can both chime in and say this, like, we don't regret the time that we spent in treatment to get better. We don't sit there every day and say we should have kept that thing going because we dedicated so many years. It's like, no, we at least figured out we didn't want to spend one more day giving into it.
And I would actually push that the regret is that we didn't find treatment sooner, right? We didn't get to dedicate that time. I think the important piece here is, do you have a choice anyway? A lot of people might say, well, I don't want to spend any more time focused on OCD. And it's like, but you're already spending time focused on it. It's already taking away time and energy from your life in a negative way. And so, yes, I get that the thought of like stopping and doing treatment, it feels like, well, I don't have time for that. But like, that's actually the best time you can spend, right? Is to address it so that you can have freedom, not where we have to keep fighting it forever, right? It's to get out of the fight and to be able to be doing the things you want, the things that are enjoyable, pleasurable, and meaningful in your life. If OCD latches onto a real event that's also criterion A trauma in someone with coexisting PTSD, would or should ERP be approached differently, and what might that look like?
Yeah, so let's say, if I understand the question correctly, OCD does do that. So a lot of times people will have OCD and they do go through a trauma, and then the OCD latches onto trauma. So an example of something I've seen before is somebody unfortunately was sexually assaulted, and the person was wearing red, and so then they had like certain kind of like magical thinking, like they had done treatment for PTSD and got into a really good place. But the one thing that stuck around was like they had OCD other subtypes, but like magical thinking for reds. They couldn't wear red, they couldn't use the letters R, E, D and stuff. And we did ERP and got passed through that. The way that I like to think about it is if OCD rather is latched on to the PTSD, and Liz, you can jump in if you do it differently. I like to touch it a little bit softer, because obviously what I want to make sure is that the person is working with somebody for the PTSD specifically, and that myself and that clinician are working in tandem, so we can really define like what the PTSD is and what the OCD is. Because ERP, like Liz was saying earlier, we're not going to do exposure and response prevention therapy that's designed for OCD for PTSD. So we want to make sure that the therapists were working in tandem. ERP is still ERP for OCD. And if we've really defined that these OCD components are OCD and not the PTSD, ERP still works. I think for me, I'm a little bit more like, I'm always collaborative, but a little bit more collaborative, and making sure that the person isn't extremely triggered in session by doing an exposure around the PTSD.
Totally. So it's really kind of twofold. Number one is if you have an active PTSD diagnosis or you meet criteria and it hasn't been treated and you have OCD, we need to treat them in tandem, or PTSD needs to get treatment first. So what we know is that ERP treatment can trigger in a negative way PTSD symptoms. And again, this is where what we talked about at the beginning of today is so critical. We do not want to treat trauma with ERP. We do not want to treat OCD with trauma treatment, which is CPT, cognitive processing therapy, or PE, prolonged exposure. And so, right, you have to separate it out. So what I mean by that is that sometimes PTSD symptoms look like OCD. So safety behaviors can look like OCD. But if we treat them as OCD, we're missing the core, and we could be actually like not just reinforcing, but re-traumatizing and different things, the trauma trigger. And so it is really important that we're treating both. Once PTSD has been treated, if it's now OCD, we can treat it as OCD with ERP, but it's really important that we're doing both. And there are providers who specialize in both trauma and OCD, and they're going to tease it apart. And then there's some providers who might specialize in just PTSD and just OCD, and you can have two providers working on both. But it's really important that you're being really, really like intentional in understanding what is my OCD, what is my PTSD, and how am I addressing them differently. One of the biggest downfalls is if we treat it as OCD, and I've seen this happen, right? So I've seen it happen where, we've been working with patients for a long time and they have really extensive shower routine, and we understand it as OCD and we're treating it as OCD. And 6 months in, 7 months in, we learn about a sexual trauma or something that actually the cleaning rituals are more a response to the trauma than actually OCD fears, but it doesn't come about till later. And we need to change our treatment course, right? We need to pause and do PTSD work around that, because treating it as just OCD and doing ERP isn't helpful. Why? Uncertainty is not the treatment for trauma. So for trauma, we're actually going to do work of like prolonged exposure, where we're going to go through trauma scripts, we're going to go through trust modules and different things. With OCD, we're leaning more into the uncertainty. We don't do uncertainty statements for trauma. They're unhelpful, they can be damaging, and they can actually re-traumatize in different ways. So for example, if somebody had someone break into their home and they've got PTSD after that, if their rituals become checking their locks, but the locks are due to that trauma, not I'm checking the lock for OCD reasons, we wouldn't want you to do exposures of like, yeah, someone might break in and something bad might happen, because that's actually going to be re-traumatizing to you compared to we might do that exposure if it's an OCD thought without trauma attached, if that makes sense. And so this is where what I was saying at the beginning is it's so important to be working with skilled clinicians who can really differentiate what are these symptoms versus what are these symptoms, and how should each one be treated, because blanket treatments don't work for multiple diagnoses.
Yeah, well said. And I know it's sometimes people feel overwhelmed having to get treatment for 2 different things. But I promise you, if you try to find a therapist that is a all-in-one and they treat 86 different things and they really don't, it can actually re-traumatize you. It can make the OCD worse. So
totally. All right, Chris, do you want to fire some away so you can have a breather?
Yeah, of course. So at 9-10 a.m., I'll do some of the live and then you could
Perfect.
do. Okay. Shilpa Jain says how to reduce hyperawareness OCD while walking. So specifically like crossing a doorway.
Yeah, this is a great question. So, Shilpa, what I would say here is that are we addressing the fear, right? So we can do what we call response prevention first. So we start to reduce our rituals. So we start to reduce maybe walking back and forth through the threshold or the doorway, whatever the ritual is. But the reality is that if we're still remaining hyper aware and we're still anxious about the exposure, then we probably aren't fully leaning into the fear, right? When we first do ERP and exposures, yes, we're going to be anxious. But eventually, when you're doing exposures, it should no longer be triggering, right? They should not be really scary and anxiety provoking. You should be able to do these exposures without anxiety and distress. And so hyper awareness is also kind of anxiety and distress, right? We're searching, we're trying to see what's going on. Hyper awareness is something like, say, for example, you have a fear of bloodborne illnesses. And so you find yourself constantly scanning the floor of where you walk to see if there's any Band-Aids or any red marks for blood or whatever it might be. It's like we're hyper aware because we're trying to make sure we're not triggered. Well, what does that tell you? The hyper awareness tells you that you're still afraid of that trigger and that you still have work to do around the fear. So the way we reduce the hyper awareness isn't actually addressing the hyper awareness itself, it's addressing the fear, and the hyper awareness should go away because we won't need to be hyper aware because we're not worried about if we're triggered or if we have these thoughts or these fears or whatever it might be specifically.
Yeah, you answered it thoroughly. The additional thing I'll add is what I see that people don't always recognize as a compulsion is they get really, really bothered. So if I'm walking with a client, like we're just, walking around doing exposures, and they're like, God, every time I walk through a doorway, I'm so hyper aware that I'm doing it and I noted it. Okay. Yeah, kind of sucks, right? It's like if you get worked up, remember all that energy that you put out there, the OCD is going to match it and double it. And so if you're sitting there getting so frustrated, I can't focus, I'll never get good grades in school, I can't ever enjoy myself, all of that energy is a compulsion and it's going to stick around.
That's right.
I'll take another live one for you and then I'll let you jump back in. Marissa at 9:13 a.m. or 12:13 a.m. Says, what is your perspective on reframing anxious thoughts? Is it helpful or does it just give the thoughts more attention?
It's a great question. I think it depends on the reframe. I think if the reframe is we're reframing it with acceptance and challenging it, then it can be helpful. If the reframe is becoming a ritual, it could be hurtful. So what I mean by that is that let's pretend I have an anxious thought of what if I get a disease after I touch the doorknob? If the reframe is something like, oh, well, people touch doorknobs all the time and they don't get diseases, so I'm probably safe. That's actually more of reassurance, right? We're actually kind of trying to calm our anxiety and we're actually responding to that fear. But if the reframe is yeah, guess I will never know that for sure, and I'm just going to keep moving on, that's a perfect reframe because that's actually an exposure, right? That's acceptance of the thought and not trying to solve or figure it out. So what is the function of the reframe? If the function is to make you feel better, probably a ritual, probably not going to be helpful and gives it more attention. If the function is to not address the fear as a fear, is to accept the thought, is to address the fear head on, probably great.
Yeah, and that's why it's always important to make sure that you get the proper diagnosis because we're going to see more reframing in generalized anxiety disorder. And so if somebody treats generalized anxiety disorder, but they're treating you for OCD and they're using more techniques for that, I see this a lot from clients that I see who didn't get better from a different treatment provider. They're constantly doing CBT thought records. They're constantly reframing anxious thoughts. They have motivated statements, quotes all around, mantras. And that's just a compulsion for OCD, even if it would have been helpful if you just had generalized anxiety.
Totally. Next question. Let's hop into Kim's question at 11. I'm not sure exactly what time, but I'm the parent of a 23-year-old son with OCD. He is a checker. We're on the wait list for help and planning to go to Boston McLean. He's having a very hard time leaving home, and I'm worried he's going to get anxious and not go, or will go but be too anxious to stay. Suggestions on how to encourage him to be comfortable and hopeful that he'll get help and relief. We're having a very hard time finding help in Michigan. Any suggestions? Everyone locally has a wait list.
Yeah, I'll let you take the part about when they're there, and I'll take the first part. what I think is so powerful that the IOCDF has been doing, and this is, I'm going to give credit to Ethan, to Jeff, and then obviously to Liz as well, is having so many front-facing advocates. You know, we just took on a brand new slew of IOCDF advocates, and what is so important is that people out there with OCD hear from other people that are getting better. I think it was Michelle J from LA said that she's starting her advocate journey. She was one of the first comments today. We need advocates. We need people that have gotten better, that found good treatment to scream it from the mountaintops. I saw Patricia B, who joins our lives earlier, and I know she's doing advocacy as a mom. And what you can do is provide them with videos, with talks from the IOCDF, things that Liz has done, because you want this, you know, your child to see that. And when they're getting kind of like, if you know, cold feet, they're getting nervous, they're getting worried, normalize that. Everybody is going to feel that way, but that doesn't mean that we have to then drop out or quit. And so I always think that when clients, potential clients, are really worried about coming to treatment, seeing somebody speak about their success through treatment and how good treatment was for them is absolutely powerful.
100%. And I think that it's twofold here, right? So number one, I just want to normalize that anxiety, distress, feeling concerned, us not being sure if it's going to work, that's all normal. Like, we don't have any patients come to residential that are like excited, thrilled, happy, and like, I'm going to do this 100%, right? Like, being skeptical, being anxious, that's normal, that's expected. And so they're going to be met with that in the sense that they're going to meet other folks at the clinic who also have had similar experiences and can share that and can normalize that. And so I just want to kind of say that. As far as getting him to go, this is the hard part, right? This is where, could there be opportunities for him to get connected with Ethan Smith and some of the live streams that we do that are Tuesday nights that are advocate based, that are really more patient based, where we talk a lot about this, about how valuable treatment can be, because that's the important piece. Is you're going to be nervous, you're going to be anxious going to treatment, but can you see the value in it? And can that value outweigh the anxiety and the nerves? Once you get there, I think the same thing, right? A patient can choose to leave a week or two in, but typically what we find happens is that they're surrounded with a community of people who understand them, people who know how to treat them, and they're also surrounded by a community of like-minded individuals who are also struggling, and that creates a lot of built-in support and a built-in relationships that have a ton of value.
Yeah, really well said, and normalize that. And one thing you can do as a parent is have them reconnect with the reasons why they think treatment is valuable. And so, you know, if your son used to play baseball but stopped because of OCD, you know, watch baseball together and talk about, like, don't you think that how exciting that's going to be, that after treatment you're going to be able to play again? That's really what people want, is to reconnect with what they mostly care about.
Totally. So next question I'm going to throw to you, Chris, was at 11:21 my time. How do you do ERP when your OCD trigger is COVID? I'm sure most therapists would only ask you to do safe exposures, but safe is subjective, and therapists aren't infectious disease experts.
Yeah, you know what? This is
Great
such
question.
Yeah, it's a great question, because I'm thinking, like, if my OCD was terrible, like if when I first got sick was during COVID, I'd probably feel the same way. I mean, I literally reached out to the CDC about houses getting tented for termites, because that was one of my big fears when I was dealing with it. And I can tell you, spending hours and hours emailing them, calling them, looking stuff up, I still never felt safe. And that's what's difficult, is the bar of safe for OCD is unreachable, because even if you find yourself completely living isolated, not leaving the house, having DoorDash ordered, etc., the OCD is going to still find something. Oh, is it coming through the vents from outside? Oh, you opened the door for too long. Did it come in? You have to eat food, but what if the person canning the food had COVID and coughed into it? I mean, the OCD is always going to stay relevant and find other things. Obviously, I mean, as a therapist, one of the things that I've been doing is keeping track of the CDC guidelines and my state guidelines, because that's what I've been using sort of as kind of the rules, because obviously I don't want to put my clients in a dangerous situation. And that's not the point of ERP. Liz and I had a guest that said ERP is not fear factor. And I agree with that. You know, the goal is to not, you know, purposely get you sick with COVID and be like, deal with it. But we also know that there's people that are being safe with COVID, but living really fulfilled lives. And so OCD has us take an extreme, and there's still clients that are not leaving the house, wiping things down. And the problem is, they're doing it based on fear, based on old information, and based on not willing to accept any uncertainty. So what I tell clients is you already have the power of accepting uncertainty. There's no way to guarantee you won't be in a car accident if you leave your house in your car, but there's certain steps you can take to be safe, and that's all we can do. And it's the same with this, is there's certain guidelines that have been put out to keep us safe. We got to follow those. Other than that, if you're creating an extra step of care that's not being extra safe, it's just compulsions.
And I would push you that, like, you probably know too, right? So most of our job as a clinician is actually following your guidance and saying something like, well, if you didn't have OCD, what would you want to be doing? And how would you want to live your life? Because you're right, the safety measures you might take, Chris might take, I might take, all might be different. One's not right or wrong because they're fluid and they're changing. But what we know is that we should not be putting people at risk, which often means we shouldn't be asking you to do something we wouldn't be willing to do. And so I would want to push you to say, okay, so what is within reason, right? If my patient is immunocompromised, I am going to tell them that I want them to talk to their doctor to determine what is safe and what isn't safe for them, and so we should be working together collaboratively with a team. But think about it like hygiene. There is no right or wrong on hygiene, right? Some people shower twice a day. Some people shower once a day. Some people wash their hands before every meal. Some people never wash their hands before they eat. Like, it's not a right or wrong, but it's what would you do, Chris, if you didn't have OCD? What is your normal? And our job is to help get you back to your normal, to your functioning, not OCD's functioning. And that's the big piece, is that when we're talking about COVID, we are not saying let's do things that are unsafe or do things that don't make sense. But what we're saying is, let's not follow OCD's rules. Let's follow what your normal rules would be, right? When you think about faith practices, for example, everybody practices their faith differently. There's no right or wrong, right? And it is not our job to change your understanding of your faith or how you practice your faith, but it is our job to remove OCD from your faith relationship so that you can be doing what you want to be doing.
Absolutely.
So many questions. So there is a question about ROOCD at 11:24. I'm going to punt that to next week. So Skyla, if you don't mind just putting that in the email for next week so that we're sure to address that, we will definitely address that. Dayton, we're having an expert on next week about relationship OCD. So
come back next week.
Yes. Kim, McLean is amazing. McLean is the first ever residential program for OCD. They are the ones that really, Dr. Michael Janicki, Diane Davey, and Denise Egan-Stack really helped start the first ever OCD Institute, which Rogers and a lot of other clinics are actually kind of modeled after. So they are incredible. They're very long-standing. I work for the sister program here in Houston, but you're in great hands. They are one of the best, no doubt. OCD and trauma. I've been seeing an OCD therapist. Chris, at 11:26, think for yourself. Are there plans to discuss transgender OCD? What it's about, examples, how is it different than BDD?
Yeah, yes. I mean, we will definitely put that down on the list. I mean, there's what I love about kind of this idea is we see it both ways. Like, I work with clients that are trans, and their intrusive ego dystonic thoughts are, should I have transitioned? Did I transition too early? Maybe I'm not really trans. Maybe I lied and stuff. So it can affect the LGBTQ community, as well as somebody who is cisgendered, who starts to have intrusive thoughts. Wait a second, am I transgender? So we can see it, in the LGBTQ community. We can also see it in people that are heterosexual and cisgendered. And so just like every other type of OCD, there's intrusive thoughts, there's intrusive feelings and doubt around one's gender identity. And so what happens is the compulsions are, I have to be 100% sure that I'm transgender, or if it's somebody who's cisgender, I have to be 100% sure that I'm not transgendered. And just like we've been talking throughout this stream, the more that you try to get clarity on your gender identity, the more you are confused. Now, this is very different than somebody, I'm not sure if you mean body dysmorphia or gender dysmorphia. So gender dysmorphia is somebody who is, maybe assigned female at birth and transitions to male. And so they feel like they were obviously born the wrong gender. That is very different. And that's similar to when people ask, how do I know it's sexual orientation OCD, or if I'm just trying to discover my sexual orientation? I mean, when you're going through, kind of stages and you're trying to figure it all out, you may be kind of coming towards your identity, your sexual orientation. It's a process and stuff, but deep down, you're just trying to process living in a world of people that don't accept you. Whereas when it comes to OCD, it's repetitive thoughts, it's intrusive thoughts. They're unwanted, they cause panic, they cause anxiety, etc. Now, if you do mean like body dysmorphia, also know, obviously the clinical term is body dysmorphic disorder. Those are two very different things. So I will sometimes work with clients, and we do have to tease out, is the BDD around the body because they feel like they were assigned the wrong gender, or is it because of BDD? So if somebody doesn't like the broadness of their shoulders and they were assigned male at birth and they transition to female, that may not be BDD. The obsession may not be around that their body part is wrong. They may just not like it because it makes it feel very masculine. So that's why I think if somebody is part of the LGBTQ community and you want to tease it out, you might want to find an affirming therapist that really understands the specific challenges someone who's trans goes through. But if you're cisgender, and maybe you could clear it up and we could answer it further next time, remember, the OCD is going to have you see something on TV with a trans actress or something, for Pride Day. You're going to start questioning, are you trans? Then you're going to find yourself going through this whole kind of thing in your head. And once again, we were talking about earlier, compulsions equal confusion.
That's right. And the big piece here I also want to say is we have done an entire webinar on sexual intrusive thoughts and OCD and sexual orientation OCD. And so definitely check that out as well, because that may be, we may have covered a lot of this in there.
My mom says hi to both of us at 11:27.
Okay, let's keep going. So my son was reluctant participating in treatment. Costas at 11:36. So I constantly count to make sure I know how many people there are in a specific place. Could ERP be to count deliberately so that I can reduce the anxiety that's caused?
Well, I think it's always coming back down to like, really, what is the OCD asking you to do? What I've noticed is people can have the same trigger, but respond different ways. So if for you walking into a certain place and your brain starts counting and you're resisting counting, you're like, no, I don't want to count, I want to focus on people, then sure, you want to lean in, always kind of doing the opposite of what OCD is requesting you to do. So for you, the most triggering situation that's going to, raise the anxiety so you can practice response prevention, then sure, walking in and specifically counting might be that. If instead you're more triggered that you can't, focus, or you'll be distract or something like that, maybe writing an imaginal, script about what it's going to be like to live life of always counting and not being able to fully focus. So you want to identify what is the core fear here that you're trying to resist and lean towards that. So sure, if for you, the core fear is that your brain's going to start counting and you don't want the counting to happen because you're going to be distracted, then try counting at certain times how many people are in the room and accept that in that moment you aren't going to be fully focusing on the conversation, and you may absolutely not be fully present if that's what the core fear is.
Totally. Last question that's pre-submitted so far, and I love this question, Lucas, is what is the right approach when compulsions become more distressing than the thoughts themselves? The thoughts don't bother you that much, but you can't stop engaging in the compulsions.
Yeah, and that happens too. I mean, especially, I've worked with people as old as 83. And so sometimes if somebody's been doing compulsions for so long, it's not, once they kind of understand the OCD treatment and they're no longer really triggered by the core fear or the thoughts or the internal cues, but it's so hard to stop. And sometimes that's because it's almost become like a ritual. There's clients that no longer care about washing their hands twice in a row, and they'll be using our sink and they'll start the second time and they're like, oh my God, I didn't mean to do that. It's so habit. So that's when it's becoming really mindful of what situations and places are you doing the compulsion. So let's say the thoughts about, contamination don't really bother you anymore, but you're still finding yourself pumping sanitizer. Being more mindful. Oh, when I'm at a store and there's sanitizer right by the cash register, that's usually when I slip up and start doing it. Or let's say you're still giving into it because you're just so used to doing it. You would want to be very aware of that situation. And when you walk at the store, it's like, no, I'm not going to do that sanitizer. And in fact, I'm going to touch something in the store I feel is dirty and deliberately not use a sanitizer at the cash register.
That's right. And I would actually push, I love this. So I always tell my patients, when you hate your compulsions, that gives us more motivation to address our OCD, right? So when our compulsions are like, gosh, this is time consuming, I can't stand this, why am I doing this? I want us to be there. When we're in a place where we're like, oh, but my compulsions don't cause that much distress and they don't take up that much time and they're not that big of a deal, we have a hard time fighting it because we don't have a lot of motivation. But if you're like, listen, like, I can't stop doing these compulsions and I'm bothered by them, good, let's address them, right? And we address the compulsions. And when we do and we address the fear, the thoughts will go away as well.
Absolutely. We have a 11:34 your time, Liz, from LinkedIn. It says OCD comorbidity. Most of our clients face more than one disorder. What do you think of the treatment suggestion that you do not treat OCD and other comorbidity at the same time?
I think it depends. I think that it depends on the comorbidity. So, for example, if someone is dealing with OCD, depression, and anxiety, let's just say, if the OCD is primary and the depression and anxiety are secondary, and I'm an OCD provider and I know how to also be monitoring depression, anxiety, and giving good CBT resources for it, they can absolutely be treated together, and I don't see why they wouldn't need to be. However, if I have a patient whose depression is primary and there's having suicidal ideation, their safety might be at risk, or their depression is so primary that they can't effectively participate in ERP, right? They're sleeping all day, they have low motivation. The depression treatment probably needs to happen first before the ERP treatment. So it's really case dependent, right? A lot of our patients, Chris and I talk a lot about this, experience distress when you're feeling emotionally dysregulated. You're experiencing distress, and how do they manage their distress? Do they have good distress tolerance skills? For a lot of us with OCD, we don't have great distress tolerance skills, especially early on. That's okay to an extent. But if when you're distressed, your lack of being able to tolerate your emotional response turns into self-destructive behavior, turns into violence or aggression, that needs to be addressed first. If what you're finding is when you're doing ERP, you're feeling distressed and it's just hard for you and you have to learn how to kind of work through distress, that's more tolerable in ERP treatment. So it really depends. We need to kind of say, what is the diagnosis, and what, like, it doesn't need to be treated simultaneously, or does one need to be treated first? Substance use, for example, there's a big debate, right? Because a lot of people will say, well, I use substances because of my OCD. So you want me to be sober, but if I don't address my OCD, how can I maintain sobriety? I understand that. At the same time, if you're not sober, we can't treat OCD, right? Because we're going to emotionally dysregulate you. We need you to not just be sober to do ERP, but we need you to be able to maintain sobriety when you're feeling dysregulated. If when you're feeling dysregulated, you are still going to use or going to engage in any sort of substance use, that puts us in a really tough spot, because ERP will dysregulate you. It's how the treatment works. So it really depends. It's hard to say.
Yeah, absolutely. And I would say too, sometimes what that comorbidity treatment needs to look like is potentially medication. If somebody is dealing with severe depression, they may need to be on a medication to help with that. I would say you could still start ERP, but maybe it's more of the psychoeducation component until the person has treated the depression and are in a place that they can start doing exposures.
Agreed.
I wanted to think for yourself. You followed up and you said that your comment was that to clarify, you're cisgender lesbian. You've been struggling with those intrusive thoughts about potentially being trans. What I would say is you're going to be really triggered right now, because as always, OCD is watching the news and loves to find things that are culturally relevant to put in our heads, right? And so because there is such a discussion on trans rights right now, I've noticed an uptick in a lot of people having this specific trigger. And so what happens is, it sounds like you just said, I like being a woman and gay. But OCD comes in and ruins that. I mean, that's your cue right there. You've been comfortable with your gender identity for so long, and because you have OCD, it's sowing in doubt. It's using societies and messaging to re-trigger you every day, and you really got to practice that response prevention. You're going to have organic triggers anytime you watch the news, etc. So it's really practicing. The biggest key you cannot do is you can't sit there and go on a mission to try to figure out your sexual or your gender identity, because you're not doing it as somebody who is really genuinely trying to find it. You're doing it out of panic and out of fear, and that's your motive, and that's why it's a compulsion.
100%. What is the right approach when is there a possibility that OCD can cause trauma?
Yeah, so it's funny, Liz, because we're in a chain about that right now. So a little behind the scenes, the IOCDF is actually creating a special interest group about this topic, because, it's been going back and forth, because, I mean, it's hard. It's like, what do we identify it as? I've had clients that have forced themselves to watch certain things because of compulsions or do certain things, and they get better, and they're like, look, this isn't OCD for me. I just really, really hate the things that I did when I was at my worst. And there's people that are married that both have OCD, and somebody's OCD made them scream and fight and break things. And, so there's all of that. And I don't, I think that's what we're kind of exploring right now. That's something that IOCDF is looking at, because, obviously we don't, I think trauma, PTSD, et cetera, is overused a lot of times. And just like Liz was saying at the beginning of this stream, like, we want to make sure that we don't water down certain diagnosis, and we really find out what things are. And we want to make sure that people that are experiencing PTSD, like severe PTSD, with where their life was in danger, et cetera, we don't start using that word too weakly. But there's a lot of people with OCD that literally have had horrific experiences because of the disorder. So how do we find that balance? And that's one of the things that we're really trying to figure out, because we know that OCD, it's not one of those disorders that once you get better, you just walk away like nothing happened. I mean, it really causes an emotional drain and emotional toll. And that's one of the talks that I'm going to be doing at the virtual conference. So please come to the IOCS virtual conference in November, and really start to explore the different ways that that OCD takes an emotional toll on us as individuals, because it really does.
100%. All right. Should we hop into more pre-submitted questions?
Yeah. It looks like we caught up with the live one, so that's awesome.
Yes. Okay, I'll let you take the first.
And Nancy, like I said, as that SIGS keeps meeting and we keep putting out more and more information, please stick in with us, and we'll keep you updated for sure. So one of the pre-submitted questions, I feel as though my just right OCD has become part of my identity. I fear that I am losing a major part of who I am by not listening to these thoughts. How do I overcome this feeling? So I'll let you tackle it first, Liz.
Yeah, this is a great question. What I want to say is that OCD always attacks the things that are most important to us. It always, it doesn't attack things that don't have any meaning to us. If it does, it'd be easy for us to ignore it, right? Or easier for us to ignore it and not be challenged by it, or for it to not get us stuck and make us question. What's important to know is that actually it feels this way, but that isn't reality. And so what I mean by that is that it feels as if we challenge our OCD, we're going to go further away from who we are, or it's going to impact like the person that we are, or our morals, or our understanding of ourselves. And what we actually find is that treatment allows us to better understand ourselves, to better be able to live by our own morals and the things we want to be doing, and our own goals and our own values. But OCD in and of itself, it challenges this, it questions it. When you're working with a great provider, what you're going to see is, again, the opposite, right? So I always think about this because it comes up a lot with scrupulosity treatment. This is the faith-based form of OCD, where people will say, well, I don't want to do treatment because faith is important to me. Like, I don't want my faith to not be important to me. I don't want my faith to not be a big part of my life. And it's like, well, of course you don't. That's why OCD is attacking it, because it is so important to you. But I bet you would love to be able to have a faith relationship that isn't controlled by OCD. And I bet you'd love to be able to have a healthy faith relationship that doesn't have rules and rigidity that OCD puts in place. And so the goal is, when we actually remove OCD, you get to live more by your values. You get to understand yourself more, your identity more. OCD makes it feel like, oh, this is all part of it and it's all tied up. But what we're actually going to find is, when you remove OCD, you get freedom to better understand yourself, to better do the things to better be able to engage in the things that are important to you.
Yeah, and I think a lot of people believe that all the good things about you is the OCD is doing. And I always tell people, like, no, if you're good at something or you're doing certain things, it's not because of the OCD, it's because of your personality. And in fact, sometimes OCD hijacks that and makes certain things, like wanting to do well on a test, too much. So I know that the just right has become part of your identity, and it feels like if you're letting it go. But I promise you, one of my clients said this once, and I was like, yes, they said that having OCD is like being in a manipulative relationship, and you think that it's doing well for you, and then you find out later on that, heck, it was absolutely sabotaging my well-being. And so I promise you, and Liz and I are testament to this, once you fight and manage the OCD, you're going to notice that all that just right stuff that you thought was doing so great for you and was part of who you were, you will not miss it. You will have a good riddance party. So I promise you that. I wanted to really quick, Liz, Tiffany, if you could email the IOCDF at IOCDF.org. Like I said, we literally have a doodle poll for our first meeting of this special interest group, and we can update you, Nancy and Tiffany. But I don't know yet if we're going to have individuals that are interested. So we'd love for you at least to email the IOCDF, and then we can keep you up to date on that.
Totally. I'm going to hop into some of the next questions that make sense for us to address. But how can we explain to our family the genuine terror and panic we feel when we're in an OCD episode? It isn't really described in the literature for family and friends. It takes time and a lot of courage to tackle our triggers using ERP. It's disheartening when we're fighting really hard and family members become angry that we can't just get over it.
I know, you know what, I've always thought of this, Liz, but I just don't have the resources. But I've always thought, or even know where to start, but I've always thought, like, man, if we could somehow create like a VR where, family and loved ones could literally, put it on. I will say I went to an interactive workshop. This was obviously way before COVID. And one of the things they did, I mean, obviously it's not even close to actual like OCD, but they had 3 boxes and one of them had or 4 boxes: a snake, a rat, a tarantula, and then like a bunny. And like parents and loved ones, it was a talk actually for generalized anxiety, but parents of kids with generalized anxiety had to put their hands in a box and pick, and they might get the bunny, but they might get one of the other things. And obviously that doesn't even almost sum up what we go through as people, but it's tough. I mean, that's why I always think if we could create a VR so family members could really see what we're going through, they don't. And I think what the best thing to do is get your family educated, have them, I always throw this out there, we have a free family group. If you are interested, you can email info@ocdsocal.org. But we have a family group that is open to anyone. Liz has been a great contributor twice this year. We're so honored to have her. Find a family group in your area if you prefer. Have them become a member of the IOCDF so they get the newsletters. Have them join live streams. It's not going to necessarily have them understand, but at least they'll learn more about it and hopefully know how to respond in a better way. One thing that I recommend, because I dealt with this with my own family, is I stopped trying to get some family members to get it. I just realized that they weren't in a space to do so. So I would definitely say that, the best thing that you can do is just have them become educated how to respond. An analogy I sometimes give is I ask family members, like, when was the last time you were in panic? And a lot of people use a car-based thing. They're driving and, yesterday on the freeway, a car almost hit me. And I said, what was that like for you? And they were like, I was in panic. I thought I was going to die. I thought my family was going to die. And I'm like, what if that was to happen about, 10 to 15 times an hour every day for decades? Do you see what your loved one's going through? I still don't think that captures what we experience, but I'm trying. We'll
there are definitely analogies, and what I've learned, and I don't know, Chris, if this was similar for you, but like my family understood and listened best when they heard it from others, just because our relationship, it was helpful to have a third party, whether that was my clinician to help describe it, or as Chris mentioned, a support group and other family members, just because sometimes when we're in the throes, like it's hard to listen to each other because we trigger each other, we say things differently. But there are lots of different analogies, and one that I often use is, there's a lot of different ones that we can use and we can talk about. But yeah, it's tough because the reality is that it's hard for us to even describe how, like, it's an internal feeling. How can you fully describe feelings that you personally physiologically feel to someone else? But great questions today. Thank you all so much for joining. It has been incredible as always. I love being able to connect, to think, to conceptualize, to hear, and just to chat, share some feedback. And I hope that you found it to be supportive, encouraging, and helpful in various different ways. Chris and I are here almost every single Wednesday. We miss one Wednesday of a month for our research roundtable, which is the second Wednesday of every month. But besides that, you will always see us here at noon Eastern time. One of us will be here as we share different insights, different experiences, and we are just so grateful for everyone who joined. So thank you so much for joining today. We cannot wait to see y'all. Next week, we'll be doing relationship OCD. And Chris, I know you have an announcement about OCD SoCal, and I'll let you wrap up. I want to end with my saying that I always say, which is that we didn't talk as much today about treatment, about hope, and about help. But I want you to always remember that help and hope are always available. Please reach out to iocdf.org for more resources.
Absolutely. And if your question didn't get asked, we're putting it on our list, but definitely please come next week. We're really excited for our guest to discuss. Shiva is a clinician that's going to talk about relationship OCD. If you are looking for a virtual conference, OCD Southern California, we're an official affiliate of the International OCD Foundation. We are having our virtual conference on Saturday, April 30th. And if you go to ocdsocal.org, you can learn how to register. And we also have free scholarship tickets for those who need it. Don't forget the Faith and OCD Conference is also coming up on May 9th. So go to iocdf.org/faith conferences. And then I think the biggest thing I'm excited and looking forward to is on early July, 8th through the 10th. Liz and I, come meet us. We will be at the 27th annual OCD conference taking place in Denver. So a lot of good resources and information. And as always, Liz and I were so honored and happy to hang out with you today. So thank you for joining us. This wouldn't be what it is without you. Come back next Wednesday. We appreciate it. And remember, Liz and I are testaments that you can get better from OCD. So take care, and we're with you and we support you. Bye, everyone.
Bye, y'all.